Welcome everybody to the Community Technical Assistance Center of New York. Our webinar for today is part 2 on the clinical implications of the crisis related to Black youth suicide. We're happy to have you back. And for those that missed part 1, please make sure to go to ctacny.org to find the slides and recording for part 1. Part 2 slides will also be posted on our website. Before I introduce our presenter, I just wanted to give everybody an update. We just launched a brand new, refreshed, updated website. So I highly encourage you to go to ctacny.org and check out all the various resources we have available for you. We have hundreds of trainings, resources, and tools. And I know many of you in your feedback also asked about what other offerings and trainings we have available to you. So if you go to ctacny.org, go to trainings, you'll be able to search by topic or keyword and see all the variety of trainings we already have available for you. So we encourage you to really just explore the website and see what interests you. For today's webinar, everybody is muted as per usual. Please use the chat box to submit any questions or comments. We will have Q&A period at the end. If we don't get to answer your question during the webinar, we'll do it at the end. As usual, the slides and recording will be posted on our ctacny.org website within about 2 business days. And at the end of the webinar, you'll also have the chance to complete a feedback survey, which we highly encourage you to do, to give us feedback both about this presentation and any future topics you'd like us to cover. So for today, I would like to introduce to you all again, Dr. Rhonda Boyd. She is an associate professor in the Department of Child and Adolescent Psychiatry at the Children's Hospital of Philadelphia, or CHOP, and the University of Pennsylvania Perelman School of Medicine. She is Associate Director of CHOP's Child and Adolescent Mood Program in the outpatient clinic, where she practices as a psychologist specializing in evaluation and treatment of youth with depression. She has served as a principal investigator on numerous research grants and participated in the work group for the Congressional Black Caucus Emergency Task Force on Black Youth Suicide and Mental Health. Without further ado, Dr. Boyd, welcome.
Good morning, everyone. I'm glad you're back for part 2. I'll be referring to some of the topics that was talked about last week to kind of try to bring it all together. So let's start. This is part 2, and these are the topics that will be covered today: barriers to treatment, engagement and service, intervention approaches, and implications for COVID-19. And some of these questions came up earlier last week. And so, as I mentioned, they will be coming. And so we will have similarly a question and answer period at the end. So feel free to put in the chats any things that come up in the meantime. So when we think about disparities, they are glaring. And so some of the things that we notice is that Black youth are less likely to receive outpatient treatment. They're also less likely to receive outpatient treatment even after a suicide attempt. And also Black youth are more likely to be referred to inpatient services or pushed into the juvenile justice system. And this is what we call the school to prison pipeline. And some of the things that we talked about last week about some of the risk factors can be the reasons why some of this occur. So I would like to people can answer in the chat, do you see these disparities in your work? And why do you think these disparities exist? We know they exist, but I wanna make sure people are aware of them, and so that we can all come together to address this as a mental health community, because if one person cannot address this, this takes a great deal of people and things at multiple levels. So let me see. So people are having trouble hearing me? Okay.
And we have a number of folks chatting in responses. So
I see that. Yes,
yeah,
so the school to prison pipeline, people see the systematic racism, marginalized inequality. So it looks like you're seeing this in your work, the provider bias, which we'll be talking about later too. Yes, so I'm glad to see that people are aware of this occurring, because I think awareness is at least the first part of recognizing that is happening, and then that we can make changes. Okay, cultural and socioeconomic barriers. Yes. No, this is great. People have a lot of ideas, and I think this is the part that we need to make sure people are aware, our colleagues, our places we work, and to be very strategic in sort of addressing these issues. Some of the disparities. Okay, no, these are some great ideas. Yes. No, these are great. I think a lot of the people took note of things that happened, and it's multiple issues, and I'll be talking about them more in detail, but it looks like the group is aware of a lot of this. And some of these are coming up with things I'll be talking about later. So it's good, they're already here. Okay. Yes, this is great. Thank you all for all those comments. And they actually cover some of the things that I will be talking about. So I know you all already aware, so we can talk about them and maybe get to some of the questions more at the end. It's great. Let's see where I got some of them. Sorry. So I want to present this study was done recently. It came out this year, and this one interesting thing is this is a large cohort across the United States of 9 to 10-year-olds, and so this is funded by the federal government. They are following these kids. The goal is to follow them for years to really understand brain develop. So they ask a lot of different questions. What they found when they looked at these youth is that kids from lower SES, and someone brought up the issue of socioeconomic status, actually were more likely to have treatment utilization. So it may not be what you think, as we say. So that is for this sample, but this is across race and ethnicity that overall socioeconomic status was included with increased treatment utilization. But they found for certain groups, Black, Latinx, and Asian, these youth were less likely to have treatment utilization. And then they found this interesting socioeconomic status and race interaction. And this is what I was talking about, this intersectionality last time, and about socioeconomic status for Black youth and what that can mean. And so actually the relationship between lower SES and treatment utilization was stronger for white youth. And this was not the case for Black youth. And so it is a difference in how we have to look at these intersections. And because this study has like thousands of people, they're able to look at this and be able to have enough people to look at this interaction effect, which is important. And I mentioned this before, but I wanted you to see the this figure of looking at, these are youth who identify having attempted suicide, thought about suicide in the last year, and you see the disparities based on race. And so it's very similar for Black and Latinx youth compared to white who actually received treatment. And this is like jarring that this is happening. And so you would think something like, okay, you had a suicide attempt, you would get treatment, but this is still not the case. And this is where we need to put our efforts to make sure that Black youth who are in need are getting into treatment. So when we talk about treatment barriers, a lot of these things have come up. The issue of stigma and cultural mistrust is still prevalent. I do think there's some shift, which I see with the younger generation, but this is still, there's mistrust that happens. There are provider biases. So when we think about, and I mentioned it last week when I was talking about how depression presents itself differently. And so there is an unusual where someone may be more irritable and how that may be misperceived. A provider could view that as a Black child is irritable. They may put them in an externalizing category and not in an internalizing category, and that miss the risk for suicide and maybe what's going on. As mentioned, there's limited community resources. And then there's difficulty sometimes getting to services, particularly where they're located. Our center is located, our outpatient, right on the train line, which makes it very accessible, but not all places are accessible in that way. Insurance still comes up as an issue, treatment costs, and many times it's sometimes even the copays that I've had families talk about, the copays and what that may mean. They may be higher, especially when a kid has more needs, mental health needs, and need to come regularly. So one of the things that has come up, which I try to figure out with patients, because some kids, and particularly those who may be at risk for having suicide, they see a psychiatrist, may see me, a therapist. And so many times, if they come in that same day, and for them it's convenience to have both appointments on the same day, that is 2 separate copays. And oftentimes I try to talk to families to make sure that's feasible. Because if they have to see the psychiatrist that week, maybe I will not see them if the copays are too high. I mean, these are some of the conversations you have to have with families to be preventative, and not that, they start missing appointments, and sometimes we don't know why. And so it's important to have these conversations up front, and knowing now some of the barriers, I try to address them early on. People, many times, if you've never been to treatment, have limited information about treatment. And so part of that is important to discuss, and this misdiagnosis is an issue. How do we make sure that we're sticking to the DSM, trying to identify these symptoms and not have our own biases based on how the person looks to impact us. And then sometimes kids have inappropriate referrals, and that's what I mentioned. They may go into the juvenile justice system instead of mental health treatment. And this is more likely to happen in Black youth. So these are many barriers. One of the things that was interesting about the Fante Coleman and Jackson Best review, that actually they reviewed articles of in Canada, which has universal health care. And they still found that Black youth, there were barriers to treatment, even with universal health care. And so these things are systemic about Black people across different countries. And I want to talk, this is a focus group that was done of caregivers and teams. And I thought I took this quote from the article, and I'll just point out some of the things because I think it gets to what happens. So one of the things is that it's both the adolescents and caregivers expected negative experiences in mental health treatment. And this issue about match, which came up, and whether they will be comfortable with the therapist. So think about how these expectation comes in. And I think someone put that in the chat about people having negative past experiences. And then also caregivers are wondering whether if they take their child to mental health treatment, would their child get better? Will it work? And I think it is a valid concern about whether Black youth actually will be getting the standard of care that is usually for other people and other youth who come in. They found that sometimes it's difficult in seeking mental health. They're concerned about what they revealed to the therapist. Would it lead to other people getting involved? And I think someone put in a chat about police, child welfare getting involved. And so these are things that may happen, and more scrutiny. And then that may get their families upset. Their friends may not be receptive to it. And their family members may think, you come to us, we keep this in the family. And some of these things come in. I think someone brought up religion, and sometimes it's also that people say, pray it out, go to, their religious institutions, whether they're Christian or Muslim. So those things come up. But one of the things that these articles, also these reviews, they talked about the facilitators, what helps get youth into treatment. And I think we know a lot about the barriers. We need to know how we can account them. How can we get kids? And so one of the things noticed was the severity of children's mental health. So when kids are more impaired, I think people see it more. And so they may more likely go into treatment. And then the caregivers' experiences, parents who had their own experiences with mental health treatment were more likely to actually put their kids into treatment and sort of understand the benefits. and then having a supportive social network. So people who can actually support you getting into treatment. So it may not be just your parents. It could be that larger circle, as we talked about last week, that kids are in multiple circles. And then the therapeutic factors, whether treatment is effective, is that there's rapport and trust. These are things that help. And so does not matter about your race when you have this type of important relationship. And religion and spirituality. So when you actually are involved with religious services that support mental health treatment, there's many churches that are involved with suicide prevention strategies and that are encouraging mental health. And those youth, when that's identified, there's more encouragement for them to attend. And then there's also referrals and mandates. So when parents and gatekeepers say, hey, they need treatment, many times it's a follow through. And then urban areas. So I'm not know, some of you may be in rural areas, and so there may be less resources available. I want to present some qualitative findings that we did. We interviewed teens that came into our clinic and asked them about like sort of how did they get to treatment? So one of the things which kind of support what I talked, the most of the youth came in because their parents or family members initiated treatment for them, or they were referred by providers. Primary care doctors are important, other physicians, therapists, school personnel, and sometimes they are coming out right from a psychiatric hospital. So this is where these gatekeepers are important. So this is one teen male said, my guidance counselor figured out that I had cut and decided that I needed help. So I know school came up and as in the context last week. And so schools are very pivotal. And to sort of maybe being able to identify youth who may at risk. And I notice if the school says you have to go to treatment, families many times follow through, at least start if they can. And so one of the things when people are looking at how do we get people into treatment, this is a study that was done a few years ago in which they focused on actually trying to help kids who came into the emergency rooms and actually had suicide risk and actually use patient navigation, motivational interview to get the kids into mental health treatment afterwards. So one of the things that they found was that the intervention actually worked, that they were able to get people into mental health treatment compared to usual care with this strategy. But the caveat, if you look at the red part down there, so they have this group that are people of color. I won't use what they say because I prefer people of color use, but the study did not work for people of color. They were not more likely to get in treatment. It worked with white youth. And so that is the part that many times we have interventions that seem good, it makes sense, but they may not work for the populations that are most at risk for not going to treatment. And so this is what we need to do. To try to figure out how to make things more specific for this population. So this is some indications. Someone looked at studies that actually focused on mental health initiation. And this is actually across all age groups, but cultural adaptation matters. Really making sure that it fits the social, linguistic, and cultural issues that come up for the population. And I think this is important when I talked last week about some of the risks and protective factors and that intersectionality and really gathering that information so that you know the youth that you're working with and being able to start this adaptation sort of in the process. Screening and referral. So I brought up last week, this, if you screen everyone, you may identify people who may not mention it. And giving appropriate referrals. Psychoeducation, really explaining what it means to have this diagnosis, what it means to have suicide risk, and how to refer them, and what happens when you get when mental health treatment occurs, what should happen, because many people may not know, and it's very different from what happens when you go to a medical doctor for health conditions than when the mental health system. And then many times the co-location, actually having mental health providers in other settings, and some of you may work in those type of settings. Care management helps, actually helping people sort of connect with different services, addressing the needs of case management, because sometimes there's other issues that may get in the way of getting into treatment. And then this whole collaborative care system has shown to be actually pretty helpful in keeping people into the same environment so they feel more comfortable and safe in those kind of environments. This study, actually, this review looked at engagement factors, and I want to talk more about sort of how do we move things forward. This focused only on child mental health, and I want to talk about this assessment issue. So one of the things they identified, these are the top ones they identified that in engagement assessment. And so we talked about last time about how do we assess. We need to screen for suicide risk. In engaging youth, the Black youth, do we understand the context that they're coming from? So in that initial assessment, we need to gather information about their family, the community, risk, protective factors, discrimination. You know, if their family have migrated from other places, those kind of information sort of help engagement, and so that you learn more about the family, so that you can be able to increase the likelihood that they may stay in treatment. And then promoting accessibility. Are our services accessible? And so, as I mentioned, our clinic is located in an easy location, but also with my schedule. I see teens, so I make sure I have times when they get out of school to be available. And sometimes that may be really inconvenient because my schedule is split up in different days, but I want to make sure that when the youth are available, that I'm available when they can come. And so some places have weekend hours, we don't, but those kind of things you may have to consider. And we've talked about it, would we have flex times so that people can come on Saturdays. So those kind of things that may promote youth of color, Black youth of getting into treatment. And then really explaining about what services are available. People really oftentimes do not know the difference between whether, family therapy, group therapy, individual therapy, what all that means. And in particular, I noticed with kids with suicide risk, where I have to talk to families a lot about is the different higher levels of care. So explaining to them, when we're trying to decide, does a youth need to go into an intensive outpatient program? How is that different from a partial program? How is that different from inpatient psychiatric hospitalization? And actually talking with Black families about these different levels of care. What is needed to seem like how they're presenting may fit. And what I recommend, but I also use that as exchange from their families. What do you think about these different levels of care and what we should do next? If I feel like the youth is having their suicide risk is getting beyond what I can do in an outpatient clinic once a week. And so we have these conversations, but really explaining this, and that helps with engaging families in treatment and that rapport. Also, they found that homework assignment is important. I do know calling it homework assignment is not really helpful because most of the time the teens do not want to think that I'm giving them any more homework, even though I think giving them things to do is very important. I just don't call it homework. And so you may call it homework. I'm not sure if that's what you do, but those are kind of things that you want them to feel like they're getting something out of it. They're doing stuff outside of treatment that it is helpful. Also appointment reminders and assessing treatment barriers. So as I mentioned before, it's important in those initial meetings to figure out, are there any treatment barriers? Because sometimes we make assumptions. And so we notice there's a whole host of treatment barriers that are possible for Black youth and their families. And so we need to be intentional in having those conversations. One of the things that came up in the quote is about sort of this talking about these issues can be emotional. And as I mentioned, there's times where someone sees both a psychiatrist and me the same day, and I have a conversation. Sometimes it's too exhausting emotionally to tell me and have me in therapy and then actually have a very similar conversation with a psychiatrist on the same day. And so I have that conversation with you and like, will it be too much for you? Sometimes they think it would, sometimes it won't. We may want to switch up to not have 2 appointments because I don't want someone to burn out and not want to come back to treatment because is too much, because we do bring up really challenging issues. And sometimes kids, and I mentioned irritability is part of depression, they get irritable, ask the same questions by two providers on the same day. And so I do note that. And so these are the kind of things that you want to note. Do you have extracurricular activities that you have to do certain days? So we need to meet on a day in which you don't, because I think it's important for kids to have participate in their extracurricular activities. And so these are the things, when you consider this and work with them, that builds the relationship, and the more likelihood that they may come back, because they know that you're concerned about their life and sort of address these issues and be sort of upfront as much as you can. I want to give an example, and then I have a question for it. So this is an example of a Black teen comes into treatment, reports that they had an interrupted suicide attempt a couple of days ago. And so a relative who was also a youth interrupted. So at that point, when they came into treatment, the parent was out of town on a business trip. And so parent was in town when the interrupted attempt occurred, but the parent was not aware of this attempt. So currently the teen was staying at home with a young adult sibling who the teen said they were not close to and didn't feel like that they could confide in them about their sibling, about, their mental health. And so currently the teen was not distressed. The parent was going to be out of town for several more days. And so the method was still in the teen's room. And so this is a kind of a dilemma, something that can happen. What are the factors I want you to put in the chat to consider in a case like this? And how do you think a therapist can respond in this situation? Staying safe list, contact a mobile crisis. Respite. Mean safety and finding ways to work with all members of family. Yep. These are some good examples of ways in which we can handle that. So we do need to make sure the teen contact a family member they can trust or neighbor. Yep. Having method moved by someone. Yep. Yes. Have method. Yes. Safety planning with parent and sibling. Yep. Youth peer advocate. I like those things. Okay. Yes. Yes. Talking about collaborative, having effective safety planning. Yes. Yes. So safety plannings come up and trying to figure out, identifying people talking through this. So yes. Yes. And what does the team want? Yes. Okay. No, these are ideas, because these are conversations, okay, that we need to have. Yeah. Okay. Now this is great. These are, people have sort of a lot of options. So these are some of the options that I think these are great things. So one of the things is contacting the adult. So although the parent is out of town, need to engage the parent, because there was a recent suicide attempt. So when you do the Columbia suicide risk assessment, this is an interrupted suicide attempt, is how it's classified. And so involving the family, also as people mentioning things, trying to identify what is hard, and many times I think that in these cases is that we can't predict very well if someone will make a suicide attempt. And so knowing that a recent attempt was made overall would increase chance that it may happen. One of the things, there was not supports at home currently. So we don't know what kind of stressors can occur. So part of it was following up with the parent, coming up with a plan of how to keep the teen safe And so what someone suggested about finding collaterals, we identified another family member in the area for the team to stay with. They came to get the team from our office. So I had the nurse wait with them so that I met the collateral. We talked about initial safety plan. So I let everyone know that the method was there. But that was a very challenging situation because the team was upset and kind of identified it as things were going to be worse because now the parent is upset to have to be called on a business trip. And so these are the kind of tough situations that many times we have to manage, particularly when we're dealing with suicide risk. But I think like things like a mobile unit can be called. Part of it is that there was not an adult there in the office. And so many times we want to make sure we engage with an adult to sort of help put the safety plan in place. Yes. Yes, and so part of it is also trying to figure out when someone said the behavior analysis piece, trying to figure out what was the trigger, talking about that. Some of the times the triggers are things that other teams maybe can manage that I've noticed that, and maybe part of my patient population that I see oftentimes are very sensitive about interpersonal things that happen, which makes it a lot more challenging. And I think people talked about doing some of the coping skills. So there are typical insults, people say things to you that get you upset that many times can escalate into, sadness, distress, and thinking that suicide is an option. And as you go through treatment, those are the things that you work on. And so trying to figure out, do they have the skills to manage what is happening? Is there supports within their environments to keep them safe, and think through those options. So I did not think the young teen needed to be hospitalized because of this, but there needed to be some supports in case something happens that they get upset about, that they won't have access. So I appreciate all the comments that people wrote in, and these are good things to consider. Yes. Yes, so there are multiple things that can be triggers that we need to do. And many times we have to find out that over time when incidents like this happen, and sometimes incidents like suicide attempts, suicidal ideation may be further, may not occur as frequently. And so that we gather this information over time. Okay. Yes. I know I'm moving on to time. I know I don't want us to run out. So one of the things I just want to mention is currently there is no established evidence base for suicide prevention tested in samples large enough in Black youth to say that we have the evidence base. So we're stuck with actually doing the strategies we currently know until the evidence base comes, and try to do the best that we can. And I think it goes back to what I said last week about, we don't know why this happening. We don't know what are the best strategies. So we have to do what we know is best, and build evidence. And I do encourage people to let them, if your clinic or the things you do work, to kind of let others know, whether you're presenting it in conferences, et cetera. I want to talk about, I'm a cognitive behavior therapist. I'm not sure, I probably didn't mention that. So someone, Robinson and colleagues, adapted a cognitive behavior therapy, the coping with stress course, which I've used in our clinic. And it's a group-based intervention, but they culturally adapted it for urban Black youth and focused it on suicide prevention. And so they did it in these high schools, and this is an example, and they found that this intervention and with these youth decreased their suicidal ideation from pre to post compared to standard care. And these are just some of the findings. They asked the youth, how did they like the program? And if you see, they liked the program, they thought it helped reduce stress, not likely thinking about it as much during it, but that happens. And they also like the session leaders. So this intervention, I think, is promising. And I'm hoping that they will be testing it in larger samples. And I do also, we talked last week about the importance of parents and positive parenting. And this is an intervention called attachment-based family therapy, which is also a promising intervention. And they've used this intervention with largely Black youth. And so they actually focus on the attachment relationship between adolescent and parent. They do a relational reframing that's focused on a relationship. They meet with the adolescent alone to identify the conflicts and help prepare them to discuss some of these conflicts with the parents. They work with the parents alone to help the parents be sensitive to the kids' issues. And I know people wrote that in some of the chat about parents not escalating things, knowing how to have this conversation. And so this comes up. And then they bring them together and they discuss the problems and practice the skills they have learned individually. And then the focus of later on in treatment is how we progress the team to more autonomy. And when they looked at the suicide guidance compared to standard care, they found it's the blue line that youth over time had less suicidal ideation with attachment-based family therapy. So this is a model that needs more studies, but it's shown to be promising for Black youth. And then MultiSystemic Therapy. This is more intensive-based, family and community focused. And a few years ago, they tested this with youth compared to being hospitalized and see what happens once kids are coming to the emergency room. And they actually found that youth who received MST actually had reduced suicide attempts over 16 months. And it also had an impact on how much parents controlled over 1 year. So the longer term outcomes weren't as effective, but about hopelessness, suicidal ideation, and depression over the 16 months. But this is showing that it's promised, at least with suicide attempts. So there may be alternatives to actually putting kids in hospitalizations that we may want consider that are more community-based. Because as I mentioned in the slide previously, that Black people are more likely to be hospitalized. I want to talk about reducing lethal means. And I think this is an important conversation. And I know it's a challenging conversation. So as part of safety planning, and this is from the Suicide Prevention Resource Center. So they have a lot of resources on there. They're not Black youth specific, but I think part of what we'll be talking about is, using this information and adapting it to the families that we see. So they talk about discussing this with the families. We have to discuss what are the means in the house. They're particularly focused on guns and medicines. Are they available? So in our clinic, that's one of the questions in our new evaluations is that we ask everyone, where is there a gun in the home? And so we gather that information so that we know, figuring out how it's stored, and depending on where you live, it may vary on how much people have guns. And then medicines, and most people have medicine in their homes. Part of it is trying to figure out how to keep it away from the youth who may be at risk for suicide attempts, and develop this plan of what they're going to do. And so sometimes kids have particular suicide plans, methods, and so we need to address them. So many times you may have to say, knives come up a lot. And so we talk about, where are the knives? How sharp are the knives? Putting up knives. And I know these things can be inconvenience and families have difficulties. And one of the things that has come up, as we talked about last week, is that the hanging and suffocations are pretty common for Black youth. And so I do talk about ropes in the house, belts. We know that nothing can be totally restrictive of everything, but really things that are easily accessible to try to remove from the house. And then you want to document this and follow up to see if the family had any issues doing this, were they able to, and then kind of brainstorm to figure that out. So yes, the razors, we talked about putting all of those things up, getting rid of all knives and any razors. Sometimes I've had parents go through the kids' room and they're not there and get rid, especially the kids who do self-harm. They go through and get rid of, because they hide them every places. And so I do have some youth who hide the different knives and things. And so those are the things where parents kind of have to go through and talk about getting everything out their way. So these are kind of things that we have to talk about. One of the things I do want to mention is there's a risk after hospitalization. And so particularly for youth that actually try to do another attempt. And so what we know is that Black youth are less likely to receive treatment. Many youth don't receive a mental health appointment soon after, but particularly Black youth don't, older and managed care, medically ill. So there is this disparity. And so one of the things that come up, I just want to present this because I know with school, that when youth go back to school, that this is an issue about reentry. And these are qualitative data that youth come from. So they fall under, there's the social emotional supports they need, academic, as well as parent engagement. And as providers, it's important for us to prepare youth for going back to school after they've been hospitalized. What will happen, their emotional, working with the schools to be able to figure out how we can reduce the workload that they have to make up, and really setting up, helping with that transition, because we do not want youth to fail. And we know that for many times for Black youth, school systems may not be that conducive to them. And so we need to be their advocates to make sure that the school will address their needs when we know they're particularly going to be very vulnerable, particularly after hospitalization. So some of the things I want to recommend is building this therapeutic rapport is very important. Part of it is getting to know the teen and the families and learning about them, and working on that relationship continuously through therapy. And not, I think people don't like just always kind of being maybe too structured and keep giving different tasks. Using some of the time, so I always allow times for youth to be able to check in, find out about what's going on, and I gather information that I use. So for example, one teen, we used to be really excited about this one rapper who I had no idea, but you know, I listened to the rapper's music, I told the teen how I listened to it and gave some feedback so they know that I care about their interests. And also that I keep track. So when teens tell me they like things or things they do, I try to investigate, find out a little bit of information, and that or if I come across it, I bring it back up. I try very hard to remember the names of their friends, their family members, the activities they do. And so I use all of that in the rapport building and be able to work on that relationship. And I think we have to listen to families and youth and learn from them. Our job is not for them to teach us everything, but we do need to learn some information and then go investigate it on our own. For example, I had a family in which they were involved in this African religion, which I had never heard of. So they told me a little bit about it. I did some research, but actually it was a productive factor that I was able to utilize in the treatment of the youth and be able to use that, their religious support as a factor that they can rely on. And it's important for us to use evidence-based interventions. We know that Black individuals are less likely to receive evidence-based treatment. And when you get back, when parents and kids are like, is this going to be effective? If youth are not receiving evidence-based interventions, it likely won't be. So we have to use what we best know. And then we need to adapt these interventions to fit the identities of youth. How do we use examples that make the fit? For example, if I'm doing behavior activation for a Black youth who is high socioeconomic status, when I may recommend yoga, that may work for them. However, I may have another youth, a Black boy, where we may talk about playing basketball as a way of increasing their behavior activation, or skateboarding in their neighborhood. And so trying to fit that to the needs of the youth based on their intersectional identities. We can use the same strategies, but how they implement it and play out may differ, and being flexible. There's times we work like over the summer. I sometimes, if school's more of a stressor, I may see kids less frequently. They get a little break from me because once school start back, they have to see me back weekly. Whenever there's an issue, I try to be available. Sometimes I have to see you twice a week when I think I'm trying to keep them out of getting higher level of care. And so I'm open to do that for periods of time. And so I think that's important for Black families, that flexibility be allowed. And then some of the system levels issues are mental health first aid. and really looking at your systems to reverse some of the biases in the system. And working to identify alternative ways to deliver services. And I think when people are in centers, sometimes you think about expanding your services. You may want to collaborate with someone at a community center, or try to figure out how to make your services available. And also doing quality improvement projects to see if it helps. So I want to quickly, I know we're going on to COVID. I want to ask people, what have they seen for COVID? And I'm gonna kind of go through, I know we're running out of time, so I would like to see, what have you seen with COVID? And I'll kind of go through the slide very quickly. How has that affected your patients? You can write it in.
And I think, are you at, I think anything specific to Black youth, but also in general, in terms of youth as
Yes.
well, right?
Yes. A lot of anxieties coming up, depression, child abuse issues. I think these are coming up. I'm not sure. COVID more often, yes. Substance abuse, yep. Isolation. These are kind of some of the things. Lack of structure, yeah.
Or not wanting to go into school or staying
Yeah.
home.
Yeah. Okay. No, makes sense. This is kind of some of the things that I've seen. Also, I'm gonna go on because I know we're running a long time. I want to get to questions or see people. So one of the things that was just noted is that when there's national crisis, the most vulnerable people in the United States are disproportionately affected. And so this is what we've seen with COVID, particularly that Black families and Black individuals have been particularly hit hard. And so one of the things that came up for me is looking when COVID hit is really understanding the milestones that kids experience and how COVID has impacted them. And it was just, I was unusual that I had about 7 patients who were seniors about to graduate from high school, and their lives were totally disrupted. And so when you think about transitions to school, you know, having the Sweet 16 and the 18th birthdays and trips and dances and sports, everything changed. And so I really was reflecting about, are these things important for youth social emotional development, which I think they are. And then we have to figure out how to do this. And so particularly with COVID, I think all the things that you said came up, this whole issue of online learning. One of the things I don't think I saw is some kids were reporting a great difficulty concentrating. And particularly learning online came up as an issue, but I think some of the other ones, I can't see. Yeah, I think everyone brought up some of the other things that come up. So I want to bring this up because we talked about people getting COVID. This actually looked at estimated deaths based on COVID of a child losing their parent. And so they estimated that there were a large number, up to possibly 43,000 youth will lose excessive deaths, that children will lose a parent. And they found that Black youth were disproportionately impacted by this. And so what I do know, I'm not sure if you've experienced any of your patients losing a parent. I have not. I've had patients lose grandparents. And one of the things which I don't know whether we will have an influx eventually of youth coming in, Black youth who've lost parents to COVID. And that may be coming as they deal with grief if it's not resolved. And so this is something I think we have to prepare for, that may be coming. And also, if you see, this is a recent study that got a lot of attention. The last line of suicide deaths decreased in 2020 compared to 2019. And so this was seen as, oh, this is great. However, this study did not show youth. It did not show people of color, and it didn't definitely get to the intersectionality of being a young person of color and Black youth. So we do not know what this means for subgroups. And so I just want to bring up, this was done at CHOP, and they found that actually the percentage of Black youth coming into the emergency room for mental health problems decreased after COVID. And so what I am concerned is that COVID is actually exacerbating the access to treatment that we already know existed. I don't know for sure, but this is one of my concerns. And so I think we have to make sure that we are not setting up systems that make things worse. And so this is just showing that Black youth are actually disproportionately impacted by COVID. Parents are reporting actually more, some of the things you said, more anxiety, isolation, loneliness, stress. Suicide did not change thoughts, but this is parent reports. So as I mentioned last time, we do not always know what parents may not know if their kids are thinking about harming themselves or thoughts of that. And so this is my last slide. We're returning to school, and I just want to think about what we think about. So what I've been doing is trying to get as much information as I can about what school will look like in the fall. And I do not know that the school systems have not really given us a lot of information. I've been trying to figure out from the families, been trying to listen to news, figuring out with kids, are their parents going back to work? What's going to happen? How much are things going back to before COVID? Encouraging them to contact their peers, friends prior to returning. Some youth have not seen their peer groups and friends for over a year, and they have a lot of anxiety about it. And also identifying any barriers to going back to school and address them. And trying to make sure that they're prepared for the routine that will be coming, sleep, how they're getting to school, all those things that come up to get them back into the routine because we know structure has changed. Figuring out, are you going back to the sport, that extracurricular activity you want to do? Or maybe you want to try something new, trying to give them that hope that they can do these things because it had stopped previously. And if they had any educational supports in school, to make sure that that's a priority for it to resume. So those are question and answers. I'm sorry we ended up running a little low on time, but someone did bring up, okay, there's a lot of needs.
Yeah. So we do have a couple questions that came in, and feel free to submit. We could probably take a couple if there's any others that want to be asked. I think it seems like for school, part of the conversation, especially since there was so many comments around anxiety and social anxieties, how do you begin sort of reintegrating back at school and being around people all the time, and then the structure of school and the like, which sometimes wasn't helpful in the past either. So beginning those conversations, I think, is important. We had a couple of questions early on. For example, is there a common suicide assessment form that you recommend? I know the Columbia screen has been mentioned a number of times. Are there any others that you would be open to recommending?
Yes, the National Institute of Mental Health is recommending ASCU, which I talked about last session. Mm-hmm. They've been using mostly in emergency rooms. I think they're moving to primary care. I know one of the things I think is important is for where you're located to figure out what is feasible, but to make it more standardized questions that you can ask and follow up so you can keep track. So we do use the Columbia, especially for the first evaluation. So we use kind of a shortened version, which I think I showed for follow-up appointments, but that we do check in all treatment points. And then there's other questionnaires like the suicide ideation questionnaire. Sometimes people use the suicide item on a depression screen, could be used. So I do think there's different measures to do, but I do think standardizing and making sure you ask is one of the most important things.
Okay, thank you. We had another question around types of treatment. For example, are you aware of any studies around dialectical behavioral therapy with teens of color?
Yes, so DBT has been effective to shown in you with kids who are more risky. I have not seen anything that focused on particularly youth of color, but I think it's coming, and it's interesting because we are doing DBT, a group-based multifamily one in our center. And this is why one of the things I do mention that when people are doing stuff in the clinical, if you could write it up to disseminate, because our team who used that, when they piloted the first group, all the families were Black. And so it was unusual, it wasn't expected. And so I've talked to them about writing that up. That was their pilot group. So they ended up and having more diversity in our DBT groups. We haven't looked at the outcomes either, though they do. And so these are the kind of things when you gather measures and be able to look at these as quality improvement projects, I think are important, because I think they will help with the evidence base while people are trying to get some of the funding.
Right, thank you. We also had some comments around how some youth actually maybe did better doing school remotely, for example, especially those who had anxiety or issues in school previously, where that piece was no longer an issue. So there's one question, for example, that said, how do you support children who were bullied in school before, and then going back and the level of anxiety increasing, that it will continue to happen?
No, I do. I'm glad, because I had thought about that, but I know I was rushing. I'm glad you brought up about some kids actually doing better, because I think that has happened. And I actually read an article, which it wasn't an empirical article. It was, a magazine article, was saying that some Black parents were not going to send their kids back to school because of some of the biases in the education system. The kids was actually doing better academically. So I do think we need to work with kids. I think also with bullying, I particularly want to switch to bullying. I know it was an initial question about working at the schools to probably eliminate bullying, because bullying is a significant issue. And I do think it's on the schools to stop it. And I'm pretty strong about that, because they have the controlling environments, and there's ways to go above. I know our city has, you can go to the school system entirely and put in a bullying report. But I do think people are having a lot of anxiety about going back. And one of the things that may be helpful with in some schools is that they'll be in a classroom with different people. And so depending on the school and how big the school is, that their experience may be different when they go back. I don't know, I'm imagining they're going to be social distance to some degree. Some schools may be wearing masks. I don't know how all that's going to play out, but I think those are the things that we have to be proactive about trying to help solve. But I do think the school should be actively involved in stopping the bullying.
Great. Thank you so much, Dr. Boyd, and to everyone who participated today. Do you mind clicking to the next slide? I just did want to highlight another upcoming webinar. Okay. In a couple weeks, we have Dr. Robert Carter doing, actually it's more of a conversation than a presentation around race, racism, and clinical practice. That's Tuesday, July 27th, 2:30 to 3:15. Please check out our website and our emails to be able to register for that, or you can just email us directly and we'll help you get connected to register for that if you can't figure out another way to do so. I think in the chat, we sent out the link for the feedback survey. I think some folks were asking for that feedback survey as well. We do review the feedback after every webinar. So please take a moment to complete that. Let us know your thoughts about today's presentation, as well as future topics and interests, because that actually, helps us figure out what to offer to you later. Please go to our website, ctacny.org, to check out all the other archived trainings, tools, and resources we have available to you. And again, today's presentation, as well as part one that Dr. Boyd did with us, will be posted on the ctacny.org website. So you'll be able to access that, utilize that. And I certainly encourage you to actually share this information with your colleagues, at staff meetings, with supervisors and other members of your team, to just really share this information, to have conversations around this important topic. So Dr. Boyd, I just wanted to thank you again for doing this two-part series. I think, there's a lot of thank yous, a lot of appreciation for the content you provided. We had a really engaged group, and I just want to thank you for taking the time to share this information with us today.
Well, thank you for inviting me, and I thank everyone for being so active and bringing up all these great ideas and talking about these issues. So I appreciate it. Take care.
Wonderful. Thank you so much, everybody. Feel free to reach us at ctac.info@nyu.edu if you have any additional questions, or you can utilize the feedback survey as well. Thank you again, and have a wonderful rest of the day.